Okay. Well, thank you, Dr. Hakeem, and thank you to the EDS Society for inviting me to speak to you today. I think it's always a real honor to come to the group and speak with, I've never seen a conference that has so much patient engagement. And it's truly a reward and also a motivation for a physician to have patients who are really so engaged and so motivated. Often the trouble lies in physicians when we complain about things over the water coolers, that this patient didn't listen, this patient doesn't understand, this patient doesn't care what I'm telling about. It's almost the opposite in this community. It's like the physicians don't care, the physicians don't listen. And so having that flipped over, it's truly an honor to be able to speak among you who are so engaged and so involved. And so thank you for this opportunity. So let's get on with it. So what we're going to talk about is the prioritization. When we talk about this topic, it's a big topic altogether, and it's a lot to chew on. And so there's, I think, a better way that we can systematically go through it and really just make it better for you all to know what to look out for and what not to look out for. When we go into it, we'll go through some specific objectives and how we can talk about it, because what we want to know is how it pertains to EDS and HSD. There's many ways that may be pertaining to you all. We'll describe the process of prioritizing, what is it we're looking for when we're making these priorities, and then ultimately review some ways that we can self-assess a little bit better. And so in doing so, I think I have a case that I want to share with you, but there's a big question that we also have to answer, which is why? Why are we making this as a priority? And it's ultimately, I think, as you identify what your goals are, and I think it's quite clear that your goals are that you want to live a high quality of life, which everyone deserves, is spending less time at the hospital, less time in front of your doctor, less money, less all of those things. And to get to that goal, we have, eventually treatments and things that we get towards. But while we're doing that, what is the purpose of that really motivates us and gets us to that end goal, gets us to the treatment, and gets us to that final point where we can live our lives functionally as high quality as possible. So this case I want to start with was a patient. We can call her Samantha. She's not exactly 48, but we'll go somewhere in late 40s. This is not her picture, but it looks like her. So she had come into my office, and she had symptoms going on for many years. I know Laura went through with some of you earlier, and it's quite commonplace that symptoms have been present for so long until a diagnosis is made. And hers were about 9 years. At one point, though, until she had a diagnosis of HSD, she had severe, sharp back pain. Came out of nowhere. She didn't have a car crash or anything to explain it. She wasn't doing her gymnastics as she did at earlier age. But she went to the emergency room as she thought she was being a good patient, that this is what she should do. She went to the emergency room again. She had 2 visits, at least at that point, where she had imaging done. She had some pain medicine given to her, and she was sent on her way. Not really any attribution to what the symptoms were caused by. She had seen a physical therapist then at that point, who suggested that yes, hypermobility is a cause of some of these conditions of pain wherever it may be in the body. You really need to speak to someone who knows about this and can help you get some coordinated care. So that's when she finally came into our office. We talked through what symptoms may or may not include. They can certainly include pain. They can certainly include acute severe back pain. She broke down in tears at that moment, just then. She had felt like she had spent so much time back and forth talking to other doctors, going to the emergency room, that was just all a waste, but that she was finally getting to a place that she could have some solace that what she was feeling was related to a real condition, but also that there may be some more specific measures and imaging tests and evaluations that we would want to go through so that she could eliminate the potential of having to go back and forth to the emergency room. She was, I guess, almost say distraught with relief. But I have here on the bottom of the slide, this story we all know about the boy who cried wolf. And I think part of it, as she was describing to me, is what she began to feel. That she had been to the emergency room, she had been talking to some other doctors, and they started seeing that she had made these visits. And so they started, brushing her off almost more and more, taking her less seriously each time that she came back. It wasn't like, oh, you've been to the emergency room a couple times, this must be really bad this time. It was almost the opposite as she described it. So she was the one that brought up the feeling like it was the boy who cried wolf. And I think that is a shared experience for many of our patients, that it's almost like the girl who cried pain. And it's, each time that cry goes out, it's minimized more and more until she finally came to a place where she needs to be seen. Now, the hard part is knowing when that comes up and who to go to and how to decide that that's the time. So that's what we'll talk through. Okay, so at least a case to get us started and understand, what is the common experience among many of our patients. All right, so let's talk about EDS and HSD symptoms specifically, because that's what we're here for. And as the conference is describing from head to toe, it can really be anything, right? I mean, it's all over the place. This is one Venn diagram that's put together by some of my colleagues. When I was thinking about this presentation earlier today, and as I was getting my breakfast, and I think have some of you all been to those breakfast buffets where they make your omelets, they put a little bit of bell peppers in here, some onions in here, some cheese in there. That's almost what like the symptoms of HSD and EDS are like, right? It's just a conglomeration of everything. Maybe a little more bacon than you want, but it is what it is. There's so many things that go together in this one omelet of a condition. So do you prioritize based on symptoms of what it is specifically? Not necessarily. I mean, you can have jaw issues, you can have fatigue, you can have the stomach issues. But just to know that almost anything is possible, I think is a good start, okay? We have connective tissue from our head to toe. We have to know that we have to be looking in all those areas as well. So those are the symptoms. This is another table that we have from our patient database. This is a sample of about 700. I mean, some larger studies have been put together with larger samples, but I think it's pretty much the same across the board. Some of these more common ones, headaches are quite high. If you look towards the middle there, brain fog is it's over 3/4 of our patients. Towards the bottom, chronic pain is historically the most common presenting complaint. But there's anything, almost anything and everything that can come up. Now, it's not to say it's just related to EDS or HSD, but there's a lot of inventory that has to go on in someone's mind, in your minds with EDS and HSD. So it's a lot. It's a lot of burden that you carry, and anything we can do to lighten that load, that's what we want to do and go through today. Central sensitization, so we know these are some features as well of the condition. So whether, again, it's the IBS, it's the chronic pelvic pain, it's all of those things that can be enhanced and can be more severe than we see in other common conditions. But when it comes to prioritization, I think that we ask the question, what comes first? It's always the most critical question to answer because there are some things that can be emergent and they can require an emergency room evaluation. It doesn't happen all the time, fortunately, but those are the ones that we have to clue into the most. When we talk about emergent conditions, it's usually related to life, limb, or eyesight. That's kind of the saying, how it goes. So if it's something that's threatening your life, and it can almost be anything from having too low sodium, too high sodium, to having a heart attack or anything in between. Risk of losing a limb, right? You had a severe accident where you've got your arms or legs that are compromised. Eyesight, obviously, anything that you can do to emergently repair those and prevent those from being lost. That's what we're talking about first, prioritization. So acuity is quite high up on that list. Now, HSD and HEDS, these may or may not take place, but we have to think about how those symptoms tie into that in these scenarios. So, and then ultimately when we're going to ask about priorities, we have to think again, what is the reason? Why are we thinking about those priorities? Life, limb, or eyesight? What are the other priorities that we may have involved though? We can decide that by looking at the symptoms themselves. Symptoms are a personal experience, right? So you know these better than anyone else. You can talk to your physician and they can tell you that these symptoms may or may not be significant, but you're the one that knows best. So your inventory of how you experience those symptoms is really the most critical piece. We can think about several ways of how you might inventory that could help you. If symptoms are new, that's a good way. It's a good strategy to decide if this is something you've never experienced in your life, and then one day this pops up out of nowhere and lost vision in one eye all of a sudden. New, or is it different? Maybe you've had these symptoms that are not new, but it's changed, even better or even worse. So that's another question that you want to ask yourself. Or finally, is it profound? Some things can be different that may not actually have any effect. Your blood pressure can change a slight amount, but it's not going to mean that you need to go see anyone immediately. Is it profound as in, for example, a headache? Is this a headache that is a little bit different, but it's what some neurology headache specialists might say is a thunderclap headache, right? This is something that you almost can't even see. You can't even get out of your bed. So new, different, and profound. These are some ways of looking at it. Acute versus chronic would help differentiate whether it's new or not. Is this something you've been experiencing for 3 months or 6 months or longer? Pattern recognition, again, when it's something that's different. What is the pattern of how you experience this typically? Is this out of that pattern? And now as far as profound and those patterns, there are things that you can use to your advantage as far as wearable technologies and monitoring and things like that. But ultimately, it's going to come from what you recognize. If you like to do journaling, that's fine. Ultimately, we want to get you to a place where you're living your life without hyper-focus on these symptoms. But if it helps you get to the point where you're recognizing these patterns more consistently and more astutely, then that's good to do. Now, the question here, though, is where do you go next? Okay, so you've got something that's new, you've got something that's different, you've got something that's profound. Well, first thing is if it matches all of those, it doesn't hurt to do some of your own research. Our patients love to do that, and I think it's great. But we just want to make sure that they have adequate follow-up from that. When I'm talking about doing your research, this is the WebMD, the Google, the Dr. Google, all of those things. And we'll have some discussion about that here shortly. But that's just fine. Maybe talk to some of those who know and have had similar experiences as well. There's lots of good discussions, forums, and support groups and things like that out there. And then ultimately, if it's more than that and you need to see someone, or maybe your friend recommended you see someone, you always want to start with your primary care, your general practitioner. Your GP is always the best line of entrance, unless it is something emergent. Now, I should have started this talk by saying, too, that this is always taken with some precaution, that if you feel like that this is an emergency, you go to the emergency room. You listen to your gut. You don't take what I'm just saying, that, oh, Dr. Knight said that this is not new, so I don't worry about it. Always do what's best for you, okay, in that case. So I don't want to dissuade you from getting the attention and care you need. But what I ultimately want to get at is you to be able to live your life as functionally, as high quality as possible with as minimal disturbance as possible. So primary care is a good entry point. And then if it is more emergency, this we're talking about urgent care, emergency room, when your primary care, your GP is not available after hours and so forth. So if you meet all of those things and you're talking about the options of where you meet the next step, it would be one of those three categories. So just a quick aside, so we'll go into a little bit more discussion on emergency rooms. But I was just talking with a colleague recently about all of this training that we do as doctors to help patients and help them see through that they not only find high quality of life, but they avoid any emergencies. They can do whatever they can to prevent it. We've spent a lot of time studying this, years of medical school and residency and training and practice experience. And it's like we get really good at managing electrolytes, doing genomic analysis, treating hyponatremia and things like that. But what do we get asked about, from friends and family? It's always the most random things. It's, I've got ear itch, I've got boob pain, or why am I farting so much? It's just really unexplainable, but these are the questions that come up, and they may or may not be tied to critical conditions. And so looking at emergency room visits, we see that the highest rates are in the young and the old. And we know that this is where the biggest concern for medical issues come from. But if we look at this middle group, there is actually an uptick from adolescents. And this is where we see most of our patients come into our clinic to begin with. So we're talking about the 20s and 30s and 40s. And we don't have differentiation from this. This is a CDC statistics on ER visits. But we suspect that there's some things that go on at this time of life that you've passed through your youth, you've done with your sports in your younger ages, and then you start approaching these medical issues with more sincerity. The red flags that come up. Now, again, this could be anything and everything. This is just really a mental exercise to think about what it could be, okay? Because chest pain, when we talk about EDS and HSD, there's lots of reasons for chest pain. And I know patients ask that, I have chest pain, it's new, but is this something that could or could not be severe? It could be. I mean, we're talking about cardiopulmonary conditions that are acute, that require intervention, things like that. It could be just more than the typical chest pain and shortness of breath. Focal neurologic deficit, those we're talking about, my hand went numb, I lost vision in my eye, a specific area, or I'm drooping in my mouth. And again, it could have specific emergent concerns, what may be a central nervous system lesion, whether it's a stroke or whatnot. Joint inflammation and then weight loss, they may not be as emergent, but there are deeper issues at hand that we may want to consider. So autoimmune diseases, malignancies, and things like that. So again, going back to prioritization, it's not always just the emergency room. These are high priority issues, autoimmune diseases and malignancies and things like that, that can also overlap with some symptoms that patients with HSD and EDS experience. So they would deserve attention as well. When we talk about, again, profundity of these issues, that's kind of the key there. So is it something that's just came up all of a sudden? Is it something that is different or more profound than usual? These are the conditions why our patients, specifically some of the rare types of EDS, might be terribly concerned about chest pain, for example. So aortic dissections, aneurysms, and things like that can be very life-limiting and do require an emergency room evaluation. Ultimately, though, when we're doing these self-assessments, I think it's important to go through it systematically. So we talked about health tracking and wearables and journaling. And again, if it gets you to a place where you're able to do pattern recognition a little bit better, having access to your medical records is pretty crucial as well, because you can see then it's there. You don't have to just try to scratch your head and remember what you did 3 or 4 years ago. It's all there, and it should be on record. So when it comes to symptom checkers, yes, Dr. Google and all of these lovely things, but they're not bad. And it's okay to start here. You just have to know that they're not going to be perfect, okay? When we have done some, and I encourage you can just go online, you can go to WebMD, you can start typing in symptoms, whether they're made up or real, and you can get a hand and see what it feels like. But what I think you'll start to recognize is that it's pretty reasonable as far as symptoms and diagnoses and potential diagnoses go. As far as risk analysis, though, it's kind of all over the map. So this is why it's good to get some more expert opinion, whether that's just someone who's also experienced it or your primary care or emergency room and so forth. Treatment options do vary, of course, based on that risk assessment. Is this something that is emergent or not? Red flags, we went through some of those things, chest pain. It's a matter of prioritizing what is going to be the most emergent thing, and then after that, what is the thing that bothers you the most? What is actually getting over that hill going to allow you to live the most functional life that you can? So when we're talking about symptom checkers, some pretty interesting technology that's going on. And I think we should go through this because this is all the rage these days, artificial intelligence and ChatGPT, and it's getting better and it's growing. And I think we will get to a place where it is truly useful. What we have right now is a comparison. So one study is looking at ChatGPT-3 compared to physicians, compared to just, they have listed as a layperson here, just the individual. So the blue bars are the layperson or the patient, the yellow or orangey bars are the ChatGPT programs, and the green bars are the physician. And what's interesting, so that the top graph is just the diagnosis, the bottom graph is the triage. You can see that the physician is pretty much across the board better than ChatGPT. There are some cases, though, that's not. And this is something to keep in mind. Physicians are fallible, human beings, and we don't have the computing capacity of some of these supercomputers, or maybe they didn't sleep well. So ChatGPT, fortunately, doesn't have to sleep. So there are some advantages in its favor there, and they are going to get better. Fortunately, physicians do pretty good for what they stand for. What is interesting, though, is that one of these triage conditions, so again, triage is just kind of saying, is this something that's emergency room related or not, or do you go to the doctor or not? The triage conditions, actually some patients were better than ChatGPT at those and getting quite close to physicians. And I think if you asked our audience here today, I think many of you would probably even score higher than some of these studies, because our patients are some of the best ones that I know of that pay attention to these things and pay attention to their symptoms and know what's important or not. But as I said, it's growing and it's getting better and better. So that was ChatGPT 3. ChatGPT 4, now in the next stage, and on to ChatGPT 5 and upwards. So this was a study that was put together looking at patients who have had extensive investigations. I don't know, that might sound familiar to some of you all, maybe. Or delayed diagnoses, again, may sound familiar to some of you all. But the outcome was that accuracy of ChatGPT 4 was better than clinicians and better than another web or symptom checker, which was Isabel. Isabel is another one like WebMD. I'll have some references on these slides too that you can go explore those if you'd like to play around with that a little bit. And I think it's worth it. It's worth just playing around and seeing what it does and what it doesn't do, because this technology is growing and it's going to be more and more pervasive and hopefully more utility. But this is just to show that the advances, the great advances that are already taking place, even just between different versions of these same large language models. We've gone through a lot now. We've talked about acuity, prioritization, what are we looking for when it comes to priorities. Let's go through a little bit of a quiz to see if you can think about it on your own. So 3 patients here. We have the first patient, so it's a 41-year-old female with HEDS. She came in complaining of a new dull headache. So new is the key word there, right? We're looking for dull. That doesn't really tell us too much, just describing the character of the pain. But it's been pretty new, 3 hours, and then it's also associated with low blood pressure, some hypotension, 85/61. So you give yourselves a second to think about this. There's no right or wrong answer, but I think it's a good exercise to just understand what we're talking about here. So to ER or not to ER. So this patient went to the ER, and I think correctly so. So always when something is new, I think that's the first clue. But it doesn't always just have to be new, because if it's not really profound, sure, you stubbed your toe, does that mean you go to the emergency room? Not necessarily. But the low blood pressure, what would be concerning to me, especially with the new onset of the headache. Now, we don't know about the treatment or outcomes, but again, we're just talking about the first stage here, prioritization. This next patient was a 19-year-old man who came in with a diagnosis of HSD. He had acute left shoulder pain after falling from a skateboard. And had excruciating pain with any movement. So obviously it looks like it's trauma related, and the question is emergency room or not emergency room. So this patient went to the emergency room, rightly so. And we talk about life, limb, or eyesight with emergency room visits, right? And I don't know that his limb is really compromised here, but it could be. And it could have been a severe fracture that was going to cause compartment syndrome that would cut off blood supply and things like that. So at least getting initial evaluation, urgent care may have been suitable in this case as well. But I think he did the right thing by going to the emergency room. So you might ask, is Dr. Knight going to show any patients that didn't go to the ER? 22-year-old female with HSD, and she had some pain at baseline. It was worse with a cough. 3 out of 10 is how she's rating it on a scale of 1 to 10. I might have given myself away here, but this patient did not go to the emergency room. And I think that's okay, because the key here is that it was at her baseline. It was a pattern that she was recognizing. It was consistent as it has been. And it was worse with cough. Usually we don't need to go to the anatomy of this, but usually this could be related to chest wall pain or pain that's related to breathing and movements of the chest that may not necessarily be cardiopulmonary. And then as far as severity goes, this is quite subjective, but just offhand, so she was recommended to watch and wait, which I think is appropriate. Of course, if anything changes immediately, then that will change the whole scope of it all. So we've gone through a lot, and I think there's so much more that we can talk about this. I'd love to answer some of the questions when we go through the Q&A, because I really want to hear what you all want to know. I really just wanted to get started on some of this, get these ideas flowing of where we need to go. And I think ultimately we all agree that you want to be at a place where you're living functionally, you're not spending time in the emergency room, you're not spending time on the phone with the doctor, you're taking some of these issues and questions in your own hand, and you can do that. And that's what I want to see my patients empowered with, that knowledge, to think about these conditions as they come up. Is it new? Is it different? Is it profound? There are tools out there. They're getting better and better as they go by. And then, so we'll just keep watch on those. Here are some list of those if you want to play around with them. And that could be fun to do as you have some time through the conference or other time. So I'm interested in see what your questions are, and I'll be glad to speak more after the conference as well if you see me around and you want to pick my brain a little bit further. But ultimately, again, what we get to a point is what is most bothersome. If it's not something that's sending you to the emergency room, what is most bothersome that's going to impede you from having a high quality of life? That should be your top priority, and that is what we want to address, and that is what will get you to a place where you can live this high quality of life that you deserve.